Mental Health, in collaboration with the Alcohol and Drug Policy Institute and the Integrated Behavioral Health Project, we would like to welcome you to the sixth of a six-part webinar series, Integrating Primary Care, Mental Health, and Substance Use Services. The goal of this webinar series is to provide information on critical policy, design, financing, and practice issues related to integrated care from the California and national perspective. The webinars cover best practices and emerging practices in the field, with presentations from state and national advocates, researchers, and practitioners. These webinars, including today's, are recorded and posted on the CIMH Integration Initiative's webpage following each event. This information will be covered again at the end of this presentation. My name is Gail Bataille. I'm an Emeritus County Behavioral Health Director, a consultant with CIMH, and the facilitator for today's webinar. Our presenter today is someone well known to many of us in California, Dale Jarvis. Dale Jarvis is a managing consultant at MCPP Healthcare Consulting, a Seattle-based consulting firm, and a member of the National Council for Community Behavioral Healthcare's consulting services. Dale has extensive experience helping healthcare plans and healthcare providers redesign their administrative, fiscal, and information systems, and has written a number of articles and co-authored 2 books on healthcare redesign and financing. Currently, Dale is focusing on healthcare payment reform to help ensure that the needs of persons with serious mental health and substance use disorders are addressed as part of healthcare reform. This includes working with states, health plans, regional authorities, and at a national level to develop payment reform strategies that align the mental health and substance use safety net systems with general healthcare reform efforts. Before we get started, a brief word on how today's webinar is structured. Following today's presentation, we will end with about 15 to 20 minutes for audience questions. Due to the limited time available and a large number of audience members, we are only able to take written questions for the presenter. To send in a written question at any point during the webinar, simply type your question in the dialog box and click Submit. We have had a wonderful response to this webinar, with well over 200 participants signing up. So we apologize that we may not be able to get to all of your questions during the webinar. Again, thank you for joining us today, and now we will begin our presentation on paying for integrated services, federal qualified health centers, Medi-Cal, and other funding strategies. Welcome, Dale, and take it away.
Thank you, Gail. Hi, everyone. I'm very happy to be here. I'm actually currently at the Red Lion Inn in Wenatchee, Washington, and actually in Yakima, Washington, in the heart of wine country in Washington State. Amazing what computers can help us do. I've made some assumptions about the folks that are going to be attending today, that you're somewhere in the process of integrating primary care, mental health, and substance use services, either in the planning or doing stages. I'm also assuming that you want to get paid for this work, and that you may not be a triple expert in how California financing is designed for federally qualified health centers, mental health, and alcohol and drug services. And you may or may not have run into the various financing barriers that folks that are working on this have been tackling and tripping over in some cases. And you'd like to expand your knowledge in these areas in order to increase the likelihood of success of your integration projects. I'm going to make another assumption that's embedded in some of the content of some of the earlier presentations, that you're working on one or both parts of what's come to be known as the bidirectional model of integrated care. And for purposes of today's session, I'm going to assume that you're working on both. And when I mean bidirectional care, the graphic attempts to illustrate that the emerging model is for folks that have low to moderate mental health and substance use disorders. Generally, they ought to be served in primary care. with embedded behavioral health clinicians and psychiatric consultation supporting the patients in the primary care clinic. And for folks with serious and severe disorders, the emerging best practice model is to actually embed a medical clinic in a community mental health or substance use delivery organization so that folks have the option of getting their medical care where they go for their mental health and substance use services, and that the services are being provided using research-based clinical design such as the impact model that was discussed in earlier seminars. A word or two about the four-quadrant model. It's based on the concept of if you take a population of folks that are, say, under 200% of federal poverty living in California who either have Medi-Cal or are uninsured, they may distribute into the categories of folks with low to high physical health risk and complexity and low to high mental health substance use risk and complexity. And there's a description of the kinds of services and the kinds of staff that ought to be available to serve folks in each of the quadrants. And again, as I mentioned in the previous slide, the quadrants 1 and 3 with low mental health and substance use risk and complexity would be provided in primary care. And generally, primary care services would be provided in the mental health and substance use organizations for the folks with the higher levels of disorders. And there's a bunch of rich information about this on the CIMH website. With those assumptions in mind, I'm going to talk about 3 chapters, some of the basics of financing of primary care mental health and substance use in California, and then attempt to answer 2 questions, or at least begin the conversation. How can we get paid today, and how are we going to get paid tomorrow? So let's jump into that first chapter, the basics of current California financing. You may realize that during this conversation I have an odd sense of humor, which is sometimes illustrated by both the pictures that I put up and the things that I say. And so I hope that you'll bear with me about that. When I think about the financing of these 3 systems, it's actually, I think about the Cinderella tale, and in this case, 3 siblings that were separated, I don't know if at birth, but in early childhood. This screen is an org chart of the Federal Department of Health and Human Services. And you'll see that I have circled 2 of the boxes, the Health Resources and Services Administration, or HRSA, which is the home of the federally qualified health centers, the FQHCs. And the second box, the Substance Abuse and Mental Health Services Administration, which SAMHSA, which is the home of the mental health and the substance use services. And for purposes of today, I'm thinking about the alcohol and drug program in California and using the SU acronym for substance use, which is the emerging term that's being used for addiction disorders. And in this, so what we have is 2 different federal agencies that are overseeing these 3 different organizations, which creates a very exciting set of rules and regulations. If we think a minute about the relative funding levels, I pulled together budgets in California for, you can see the categories of health, mental health, and the alcohol and drug, broken up into Medi-Cal and non-Medi-Cal. And what's quite noteworthy to me is that the health bars represent about $41.3 billion a year and substantially dwarf the mental health and substance use bars. And in fact, the drug Medi-Cal and alcohol and drug federal, state, and local blue bars are almost so small that you can't see them on this page, which gives us a sense of the relative funding levels of the different systems in California. And as I was going through and thinking about this, I said, oh, you know, 88% is health, 11% mental health, and only 1% alcohol and drug. 90% of the funding is Medi-Cal and 10% is non-Medi-Cal. And it was interesting to think about the 90-10 in relation to the third box, which is that the Medi-Cal enrollees represent 61% of the safety net population, those under 200% of poverty, and the indigent and insured in California represents almost 40%. So here we have 90-10 funding split, but a 60-40 population split, which is, as we all know, there's if you're uninsured and indigent in California, pre-healthcare reform, it's much harder to get access to services. I've been thinking about the California funding flows from a different angle, which is how does the money flow in terms of fee-for-service, capitation, different pots and funding streams. In this slide, which could be a 30-minute conversation about some of the details, it really represents, for purposes of today, a patchwork quilt of a lot of the priority populations that are going to be focused on in the 1115 waiver renewal, which we'll talk about later, are mostly in fee-for-service on the healthcare side, but have different funding mechanisms for the mental health Medi-Cal and the drug Medi-Cal. The other piece of the puzzle that relates to both this slide and the previous one is a lot of the folks that have non-Medi-Cal funding, that are indigent and uninsured, and whose care is funded with non-Medi-Cal sources, are going to be coming into Medi-Cal with Medicaid expansion or into the insurance exchanges as healthcare reform unfolds in 2011, 12, 13, and 2014. And that will be the subject of our third chapter in terms of how you're going to get paid tomorrow. Let's now think about each of the three systems and sort of what I would describe as the cliff notes of how the funding is organized, so that we're all working with a common foundation as we move into how to get paid today for integrated services. The mental health side of the funding stream has this what I would call a typical funding structure for Medi-Cal mental health, where there are these Medi-Cal mental health plans that are regulated by the federal government and operate under contract with the California Department of Mental Health. In California, there are 57 health plans, with Sutter and Yuba being combined into one. And the way the funding for the Medi-Cal portion of these health plans work is there's federal dollars that are matched with state dollars, and the state dollars are paid through realignment funding and Mental Health Services Act funding. And on the realignment side, it's a combination of sales tax revenue and vehicle license fees that come down to the counties for a number of purposes, including social services, health services such as the CMSP and MISP funding and others, and the mental health pods. And so these dollars are controlled by the counties, who then distribute them, some for the Medi-Cal services and some for non-Medi-Cal services to Medi-Cal enrollees and services to non-Medi-Cal enrollees. A few more things about the mental health funding. In California, the mental health funding is primarily fee-for-service with a back-end cost report settlement process. And there's this thing called the SMA, the Schedule of Maximum Allowable, so that there's a governor on the cost report. If your costs in a given county are above the SMA, then you only get paid up to the SMA, plus additional funding for administrative and quality assurance activities. And as folks design their integration efforts, basically they need to go through a process. You know, some of the counties are saying, okay, should we be billing Medi-Cal services for mental health and substance use in the integration through the mental health system, through the substance use system, through the FQHC system? The answer is it depends on how you run the numbers and what actually ends up working best for you. What we found is that there's no one right answer to this. We'll be talking about this more in Chapter 2, but it is something where I can't give you, it's always better to run everything through the FQHC or always better to run everything through the mental health or drug Medi-Cal benefit. Realignment in some of the MHSA funding serves as a state and local match, as I mentioned before. And one of the things that's important is even though mental health is paid fee-for-service or primarily fee-for-service, it's not a blank check. Because if you use up all your realignment, it means that you can't draw down any more federal dollars to match. And if the sales tax levels drop, if the vehicle license fees drop because people aren't purchasing new cars, it means likely cuts to your funding even though the federal dollars are still there for match. The last thing to say on this slide about the mental health funding is the majority of the public mental health services in California are provided by county employees, supplemented by nonprofit and other community providers. And the ratio of county to non-county employees providing services varies from county to county based on the local designs that they created and the availability of providers in that community. A word or two about the MHSA funding. For those of you that don't know the details, the Mental Health Services Act was passed in 2004 via what's become known around the country as the famous Proposition 63 that created a pool of funds based on 1% of income tax, and that for people whose incomes were above $1 million, generating over $1 billion a year. We can see from this slide that we have estimated and actual receipts. And you'll see also that there's 6 categories of funding, with most of the money being paid for community services and supports, is what the category is described, which is outpatient and intensive outpatient services for folks in each of the counties. When the bill was passed, there was a clause called non-supplementation, and as the code says, the funding established pursuant to this act shall be utilized to expand mental health services. The operant word here is expand. They shall not be used to supplant existing state or county funds. So the idea was we didn't want to create a situation where the MHSA was passed, new money came in, and then other budgets were cut so that a given county would have the same amount of money for mental health just from the MHSA tax. And this has been a somewhat controversial issue as the state has tried to remove this so that they could reduce funding obligations to help balance the budget in California. Another piece, though, is people go, wow, isn't California rich? They've gotten $1 billion worth of funding from MHSA, so they must be better off than the rest of the country. And what I've been studying for many years, how much money goes for mental health in each of the states compared to one another. And what keeps coming up year after year, even with MHSA funding, is that California has roughly only half the funding needed to meet demand, which is consistent with a Little Hoover Commission report that came out a number of years ago. This next slide shows the way that I've been crunching the numbers. This is taken from a larger analysis, which has a row for each of the 50 states. And what I've done is I've sorted the rows by the most well-funded state, Pennsylvania, down to the least well-funded state. And I went about 20 deep for this slide so that you could have at least a chance to read it. And what you see here is that California, down near in my little circle, funds the public mental health system to the tune of about $2,100 a year per person who ought to be receiving mental health services based on prevalence data. And the question becomes, so is that $2,100 a year a good amount, a bad amount? Well, you have to answer the compared to what by looking at the other states. I've worked in a number of the top 10 states, and basically because mental health services are generally not adequately funded in many places and not overfunded anywhere that I've been, I've considered the average of the top 10 as a proxy for an adequately funded system. And that number is $4,472 a year per target client. So in other words, if California is at $2,100 a year and the average of the top 10 is $4,400 a year, California actually has less than half the funding of the average of the top 10 states. And what was interesting is that's very much in line with the findings of the Little Hoover Commission. The thing that's most interesting about this is the Little Hoover Commission report came out before the MHSA funding, and the MHSA funding basically has helped California keep up with inflation, if you will, but not allowed California to approach the funding levels of some of the more well-funded states. Hope that's clearer than mud, as I've used however many words to describe this slide. Let's shift gears and talk about alcohol and drug. The thing that's, I guess I would say, most exciting about alcohol and drug is how many different funding sources there are. It's a combination of funding that goes to the state and is managed by the state, funding that's managed by the county. Each of these funding sources has their own set of restrictions and target populations. And if I created a pie chart, about a third would be drug Medi-Cal, about half federal grants, and the other 6 would come from other state funding sources. And the funding levels in drug and alcohol are even further from approaching meeting the needs in mental health. We got a sense of that from the size of the bar charts on the previous slide. One of the things that's going to be a real challenge for California is because the alcohol and drug funding in California is so low. There are many experts that believe that California is going to be found significantly out of compliance as the new parity law kicks in and the feds start taking a close look at whether the Medi-Cal systems in the state, the Medicaid systems, are meeting parity in terms of both mental health and substance use. And so this is going to be a challenge that's going to have to be tackled at both the state and local levels. This next slide was put in for the purpose of just illustrating at the high level the number of funding sources. And if you think about each row having its own population that it serves with its own set of funding requirements, it's truly a challenging environment to really manage a drug and alcohol benefit in the state or program. Another issue with the drug and alcohol system in California is there's been a real concern by a number of counties and providers throughout the state that the drug Medi-Cal rates, which are set by the state, are not adequate to cover the costs. And it creates a barrier for building programs throughout the state and acquiring enough provider capacity, because if the providers are not able to cover their costs doing this program, it's just hard to find providers to do the services in a number of places. The last slide in the alcohol and drug piece is the triangle that was developed by Tom McClellan. And basically, the triangle represents everybody that lives in the United States. And there's some squiggly line at the bottom that delineates folks that have little or no substance use to folks that have what's called unhealthy use. And if we take that part of the triangle and say, okay, let's put that off the side to the moment and think about the top 2 slices of the triangle. There are 23 million people in the United States that are estimated to have substance use, abuse, or dependence situation that ought to be receiving treatment. There's about 2.3 million of those folks that are actually in treatment, which represents 10%. This is one of those Houston, we have a problem situations, because of drug and alcohol substance use being so poorly funded throughout the country. And the problem is substance use conditions increase the total health care costs for folks that have abuse or dependent problems and also folks that have unhealthy use. And in order to bend the cost curve to help prevent the healthcare system from bankrupting our country, we're going to really need to address the substance use condition needs of folks in a much more robust way than treating only 1 in 10. And so this is a situation that really illustrates the gap between how many people are receiving services and how many people ought to be receiving services in order to bend the cost curve. And we'll talk a little bit more about this later in terms of why it's important to adequately fund substance use services, in addition to the fact that the law says that you need to do that. But first, let me shift gears and talk about the FQHC program. You'll remember back on the org chart slide that FQHCs are managed by HRSA, the Health Resources and Services Administration. Well, let's dig down one level below that and look at the HRSA org chart. And you'll see that down in the lower left-hand corner, there's this thing called the Bureau of Primary Health Care, and that's where the FQHCs live in terms of their organization and management and rules and regulations. I'm going to just call this the Bureau for shorthand as we go throughout the rest of the slides. The definition of a federally qualified health center is in federal law and regulation, and it's officially an entity that receives a grant under Section 330 of the Public Health Service Act. So when you hear about the 330 grants, those are the funds that go to FQHCs to pay for uncompensated care for people that don't have Medicaid or insurance. An FQHC is a health center that serves a population that's medically underserved, or a special group of folks such as migrants, homeless, or residents of public housing. And it's provided with these health centers provide a required set of primary health services, either through staff that work in the clinic or through folks who work under contracts or cooperative arrangements. There are 5 types of community health centers to make the discussion a little bit more complicated. And you'll see that there's these 330E, G, H, and I. Most of the health centers are under the 330E program that are the community health centers, including school-based health centers, or the migrant health centers. And there's also healthcare for the homeless type centers, public housing centers. They each have a little different set of rules and regulations. The 5th category is what's called an FQHC lookalike, so that a center that, an organization that decides to start a health clinic that is able to follow all the rules for being an FQHC without getting a Section 330 grant can apply for that, and if it gets approved, it's called an FQHC lookalike. So the difference is the FQHC lookalike doesn't get the 330 grant money, but they do have many of the rights and responsibilities and benefits of being a full-blown FQHC. Now, the FQHC world has been unfolding for 50 years, starting in 1962, and then in the 70s, we started getting a little more clarification of these 330Es and Gs. So we had the first 2 set of categories that were approved. And also the National Health Service Corps began, which stationed stocks in these community health centers in medically underserved areas. In the 80s, the Healthcare for the Homeless program was added, and the term FQHC came into being. And this cost-based reimbursement model for Medicaid and Medicare started up in the 80s. In the 90s, FQHCs were given malpractice insurance coverage based on a set of rules, and the Public Housing Primary Care Program was added. And then in 2000s, cost base was tweaked and called prospective payments, PPS, and states were explicitly required to cover the difference between whatever they were paying the FQHCs and what the FQHC's PPS rates were in order to really establish these centers as safety nets. And there was also the expansion of funding and capacity, adding behavioral health services. What's really fascinating about the FQHC world is since the beginning, it's been a, if you will, a pet project of both the conservative Republicans all the way to the liberal Democrats, with Orrin Hatch and Teddy Kennedy being two of the biggest supporters of the community health center system in this country. It has broad public support and is seen as a very, very important safety net system, which it is. In California, the California Primary Care Association has been officially designated by the Bureau as the state primary care association, and as such they receive dollars to develop and enhance services for the 800+ member clinics. Not all these clinics are FQHCs, and county FQHCs are not members. And then two more sort of tidbits. The California Department of Public Health licenses FQHCs, and the California Department of Healthcare Services interprets the federal policies regarding FQHCs. But it's important to note that the feds set most of the rules for FQHCs that supersede, and states can't trump these federal rules. So if the state passes a rule that conflicts with federal regulations, basically it's not going to stand up. And most of the federal rules are issued through these things called PINs and PALs. And so two more acronyms, if they're not already in your vocabulary. If you're getting into the FQHC world, it's very important to know what the PINs are and to stay on top of new ones that come out. In terms of the payments, I already mentioned that there's this prospective payment system. It gets translated into an all-inclusive rate per visit, which is an encounter with an approved provider providing an approved service at an approved site. So the regulations are pretty clear and straightforward. There's also a wraparound process in California to cover the difference if the money that flows to the FQHC during the course of the year is below what the prospective payment amount is. The FQHC can apply to the state and basically have the difference made up. Unlike some other states, California does not require the submission of annual cost reports. Now there are 8 benefits and 8 responsibilities of FQHCs that I'm not going to go into a lot of detail about, but I included them in the slides so that you could have them as a take-home to get a flavor about the fact that there's the operating grants with a little bit more detail, the prospective payment system for the Medicaid reimbursement, some information about Medicaid enrollment workers, Medicare reimbursements, and the access to federal loan guarantees for capital improvements. And these are all things that are available to FQHCs that are not available to primary care clinics that aren't part of the system. There's also favorable drug pricing, some antitrust protections. I've already talked about the malpractice insurance coverage, and then National Health Service recruitment. And then there's also a number of quality improvement efforts that are funded through the FQHC system that have really helped the FQHC system really have the reputation that it carries throughout the country. I won't go into the requirements now, except to say that there's a handful of requirements that are federally driven that describe what you need to do if you want to play in the FQHC arena. And it's very important to be able to demonstrate that you can meet these requirements and continue meeting these requirements, or basically you get busted by your project officer. I don't know how many of you know this, but this next chart is Dale's little graphic of what's written in the healthcare law, that FQHC funding, the grant funding, is going to go from $2.98 billion to $8.33 billion over the next 5 years. It's going to triple. And again, it's acknowledging that FQHCs are a critical component of healthcare reform, that we can't solve the healthcare crisis without robust primary care, without a really strong safety net system for primary care. And so this is a really important piece of the puzzle as we think about what are the opportunities for drawing down some of these funds in California over the next 5 years. The last thing I want to say about the FQHC arena is there's this new acronym called Federally Qualified Behavioral Health Centers. And there's language from the healthcare reform bill that didn't make it into the final bill, but it's in the process of resurfacing through a bill introduced by Congressman Kennedy in the House, and it's going to be introduced as a bill in the Senate shortly. This is a really important thing to put on your radar screen. The idea here is, if you think about the benefits, the funding levels in the primary care side for the safety net, and then you think about attempting to achieve parity with mental health and substance use. Right now, we don't have parity in the federal support for the mental health and substance use delivery system like we do for the primary care system. So this bill is really, if you will, the service delivery safety net parity bill that attempts to help the mental health and substance use systems throughout the country get on an even keel and on an even par with federally qualified health centers, so that these mental health and substance use providers can have the benefits, build the strong infrastructure to really be able to be as strong a partner as possible with the FQHC system as we move into a world of integrated care. If the FQBHC bill passes, it's going to be 18 months, no later than 18 months to issue the regs. And basically what's going to happen is, if you're a mental health or substance use provider on the call, you're going to want to focus on, what is it going to take for me to become a federally qualified behavioral health center? How much am I ready now? Do I have all the pieces in place? What else do I need to get in place to be able to get over this bar? Because I think it's going to be a very important piece of achieving parity in the delivery system. Because the regs have not been written yet, I can't answer that question, but it will be important to keep this in mind. Okay, let's move on and talk about how we get paid today. I'm suggesting that there's a 6-step integration game plan that is really a reflection of what a number of folks in California and other states have been doing to develop their integration plans. Designing a clinical model, identifying and addressing the funding barriers, crafting an integration budget based on grading and blending funding from the various funding sources, and then revising your business processes and obtaining necessary approvals. I'll talk about all these in just a minute in more detail. Designing your implementation plan, and then monitoring and adjusting your plan as you move forward. There's a IBHP toolkit that has more details, and you can see the web link at the bottom of the screen here, and you can pull that off the slides. Now, in terms of how we get paid today, it's important to say that California is, I consider, to be a state that's leading the way in primary care mental health substance use integration projects. There are projects in many, many counties around the state, and there's all sorts of sort of barrier busting, funding, grading, blending that's going on around the state. So the best expertise is really embedded in what real people have done in real time in their communities. If we think about the steps that I've listed, the first one being designing the clinical model, using evidence-based practices. This is an example of a design that's being used around the country called the impact model, based on stationing primary mental health and substance use clinicians in primary care for folks with low to moderate mental health substance use disorders. And I just want to take a moment and say, think about a world where most of the safety net folks in California would have a Medi-Cal benefit or be in the exchanges. And let's pretend that somebody went from being uninsured without a primary care provider to getting coverage under healthcare reform, having a new primary care clinic. Their first visit, they would come into the clinic and they would be screened by their primary care physician for mental health or substance use disorders. And if the doctor or nurse practitioners identified the possibility of a mental health or substance use disorder, they would be walked down the hall to a behavioral health clinician who's working in the clinic, and a full assessment would be done. And if they needed behavioral health services, one of the models that's being used is a decision that's made: should they be served in primary care, or should they get their mental health or substance use service in a specialty clinic? And if the person is served in primary care, then they're enrolled in this is a Washington State model that's being used in what's called a level 1 service, where they're case managed and served in primary care by basically 3 folks: the primary care provider, the behavioral health care coordinator, and a consulting psychiatrist who supports those 2 folks. And if the condition can't be addressed in primary care, the person gets stepped up to specialty care, just like someone would go from a primary care provider to a cardiologist for specialty care. And just like the primary care clinic continues to manage the patient when they go see the cardiologist, that would continue to be the case too, so that there would be a second provider organization brought in working closely with the primary care clinic. So hold that model in mind as we think about some of the barriers and some of the budgeting issues, because you really need to start with what's the clinical design before you can answer the question as what are the funding barriers and what are the payment sources for these folks. Let's talk about barriers for a few minutes, because all healthcare is local. There are these, what I call ecosystems, integration ecosystems that have evolved throughout California, where they've been tackling the different pieces. And from that work, there are 6 sets of issues that have been identified around funding barriers. What we know is that some things currently can't be paid by primary care, some of the integration work. Some can't be paid by mental health. Some can't be paid by substance use. So it's very important to sort out, based on current rules and regs, what can and can't be paid. One of the caveats, and actually one of the frustrations about as I was preparing for this presentation, is there are lots of financing barriers that folks have identified that are simply the result of federal or state laws or regulations, and we can't bust the barrier until we change the law or regulation. And so I sort of think about this as a serenity prayer moment, where I have to sort of sort things out into things that I have to accept for now because I can't change them today, and then really to go ahead and work on the things that I can change. And so what this does is, as we think about the barriers on the next few slides, it pushes a number of issues over into the how do I get paid tomorrow category, because there's really the law is the law, the regulation is the regulation until it gets changed. This is a picture that I'm going to just show you as sort of an at-a-glance view. Don't worry about the details because we'll look at those in the next few slides around what came out of some of the work that's been done in California to identify barriers, in particular in 6 areas. And let's talk about some of those. Service codes and allowable costs. If you are going to attempt to have mental health and or substance use services paid for by the FQHC, it's very, very, very important that you follow the FQHC rules, and there's this thing called the scope of project that covers, and what you have to do to get approval to be an FQHC is you have to say, what are the services I'm going to provide, where am I going to provide these services, and what are the types of providers I'm going to use. And if you're going to expand services to include mental health and substance use services that haven't been billed through the FQHC before, you need to expand your scope of project. I've listed the PINs that provide, remember the acronym PIN, Program Information Notice, that provide guidance for this, one that was issued in 2008, one that was issued in 2009 for guidance. And you need to make sure that you obtain prior approval from the feds before you proceed with providing mental health and substance use services in the FQHC that you're expecting to get paid for by the FQHC. The second issue I want to touch on is there's been a lot of concern and a lot of problems around a patient coming in. Think about my example of seeing the primary care doc and then being walked down the hall to the behavioral health specialist to get an assessment. Well, that's two services that get provided in the same day. And in California, unlike a number of other states, there's a regulation that says you can't bill two services in the same day. This is not a federal issue, contrary to what many people think. The feds have been very clear. It's just fine with us to do that. We understand the importance of this clinical model. This is a California law that needs to be changed. In 2009, there was a bill that was introduced, AB 1445, to allow up to 2 visits per day in both FQHCs and rural health clinics, RHCs. And we first have to pass the law in California before we can go through the process of changing the regs. This is a very important thing for supporting integration because it's a real funding, it's a real live California-created funding barrier. Another issue is the fact that in the model that we were talking about, what we're looking for is psychiatric consultation to the behavioral health specialist and or the primary care provider. Generally, this is done by telephone. The psychiatrist doesn't see the patient isn't on the caseload of the psychiatrist. And this is an issue that has to be addressed through healthcare payment reform because right now we can't bill FQHCs for this type of service through FQHCs. So it's an issue that really needs to be changed but falls into the category of how we get paid tomorrow. The same thing is true for email visits, telephone visits, telemedicine. They're not billable, and it's a federal regulation that hasn't caught up with current practices. What's interesting is I live in Seattle. There's this organization that's actually part of Kaiser now called Group Health Cooperative. They've been working with great vigor to develop their medical home model to really help better manage the healthcare costs and improve the healthcare outcomes of the patients that are members there. 30% of the primary care visits now are done by email or telephone. And they do that because they get capitated payments and they don't have to bill on a per visit basis or a fee-for-service basis like the mental health centers, the substance use centers, and the FQHCs. And it's really been a huge piece of their improving their healthcare delivery system. Another piece of the puzzle that's noted here is that there's all sorts of different folks you have to get approval from in California. It's not a one-stop shopping. You get certified to provide different services of different types in different places. And again, this is something that needs to be addressed as you move forward with healthcare reform. Right now in FQHCs, you can't bill marriage and family therapists and LPCs, licensed professional clinicians, But guess what? The federal reform bill has said, and let me quote it, an individual with a graduate or postgraduate degree in substance use disorder prevention and treatment, marriage and family counseling, school counseling, or professional counseling are now recognized by the feds as being able to bill federal programs, including Medicare and Medicaid. So this is an FQHC regulation that's going to need to be updated. There may be some things that California needs to do, the California Medi-Cal system, but in the near future, you should be able to bill more folks through the FQHC system and also to Medicare than what you're able to bill now. We still have a problem with non-recognition of team-based care, and again, it's going to need to be something that's addressed in healthcare reform. There are a number of service limits, as this slide talks about, throughout California, and on the mental health side, the Code of Regulations makes it difficult to provide mental health services to mild to moderate need, and there's a set of descriptions about what those restrictions are. And it also lists as excluded services for county mental health programs, services that are provided by FQHCs and rural health centers, and so this can create a challenge depending on how you're designing your integration model. And the 1915 Medicaid mental health waiver is coming up for renewal in about a year, and we really need to think about changing the waiver to support integrated care better than how it's designed right now. When an FQHC expands its scope of practice, like I was talking about, to add services, sites, and providers, one of the things that's important to note is that the FQHC has to make those services available to all patients, both uninsured and those with Medi-Cal. So you really can't say, oh, we're just going to add mental health and substance use for California for Medi-Cal enrollees only, because we go broke if we provided these services to the uninsured, and that's not an option. So some of the clinics, some of the projects that are trying to expand FQHC billing for these services have run into problems because they don't know if they're going to be providing a lot of mental health and substance use services through the FQHCs to uninsured persons that are going to create a financial problem. And so it's important to take that into account when you're doing your budgeting for that. Now, the California waiver renewal with the expansion of the coverage initiative and Medicaid expansion, which I'll talk about more in a few minutes, is going to radically alter this because, again, I mentioned a lot of folks that are indigent and uninsured are going to get coverage, and it will go a long ways towards eliminating this barrier. I mentioned this before, but there's a great deal of local expertise that we have that can help us understand what we can and can't do. I'd like to direct your attention to Volume 3 of the IPI report. And CIMH is attempting to obtain funding to develop a toolkit of promising practices for financing integrated care in the California safety net. If this is sort of the brief overview of some of these issues, what we're trying to do is pull together all the work the hard work that's been done across the state into a toolkit so that we can give you much more detailed examples, suggestions, explanations of things that have been done in places like San Mateo, Santa Claus, isn't that a Freudian slip? Stanislaus, who I've worked with for a long time in San Francisco, to really help folks around the state not have to reinvent this wheel. We're not able to cover this in one webinar and also without doing further research. The next step is to budget who will fund what. And what's really important to do is, and I'm going to be a broken record around this, is you need to budget the clinical design, so you have to start with your clinical design. And in my example, using the impact model of mental health and substance use care and primary care, it's looking at the cost of the primary care physician, the behavioral health professional, the consulting psychiatrist, what are the services they're providing, where's the site, what are the funding sources, and really building your budget framework and then making sure that there aren't any barriers to the expected source of funding for these pieces. Putting a primary care team in a mental health center or substance use center is also based on some of the research that's been done, one model is to have a nurse practitioner, one or more, a nurse care manager, and a primary care supervising MD, and working and supporting primary care services in the mental health or substance use center. And in this case, I'm projecting that the scope of project would be expanded and these folks' services would be paid for by the FQHC. So I'm thinking about what are the services in the primary care clinic, the mental health substance use, what are the primary care services in the behavioral health clinic, who are the funding sources, and as you can see, I'm talking about using FQHC money for primary care in the mental health center, and mental health, in this case, funding for services in the primary care clinic, including MHSA prevention and early intervention services that are being used in California to pay for these services in primary care. In terms of revising your business processes and obtaining approvals, again, I'm being a broken record, but does the FQHC need a change in scope of project? You need to answer questions like who will own the charts and how will the documentation be shared? Will a shared patient registry be implemented, which I don't have time to go into, but if that's not a familiar term, you should make sure to make it a familiar term to you. And what outcome tools and measures will be used, and you need to think about productivity standards because FQHCs have productivity standards that are different than what are in mental health and substance use. Finally, designing your implementation plan and then making sure you monitor and adjust. One of the things that some of the sites have found is that productivity levels that were anticipated by the primary care providers ended up being lower because of higher no-show rates in the mental health centers than in the primary care clinics. I'm going to spend the last few minutes talking about how we're going to get paid tomorrow. I know that I'm sort of rushing through it, as a whirlwind, but again, we'll have time for Q&A, and we're really hoping to put together a much more robust toolkit. So let's stop a moment and think about healthcare reform, which I think is going to dramatically change the healthcare system in California and the rest of the country. And the three things that are going to change have to do with universal coverage. Most folks will have some type of insurance at parity, delivery system redesign, including the implementation of medical homes throughout the country, and these things called accountable care organizations, and payment reform. We're going to, you guys are on the leading edge. One of the states on the leading edge are on integrating mental health and substance use services, and we're going to see this rolling out and just becoming the normal course of business in the healthcare system. It becomes more important than ever because people are very quickly realizing that we can't achieve the quality outcomes and cost reduction goals without integrating mental health and substance use services, especially for systems that have served the safety net populations because of how expensive the healthcare is for folks with mental health and substance use disorders. This next slide represents what I would describe as the big fix. Right now, we're spending a great deal of money in inpatient care and specialty care because we're not spending enough money on prevention, primary care, including robust early outpatient mental health services and prevention and early intervention related mental health and substance use services. We can't fix the health care problem without inverting the triangle and providing a lot more funding for prevention, a lot more funding for primary care so that we can decrease the demand in specialty and acute care systems. And when I think about the green box of prevention and primary care, it also means that we need to be providing more mental health and substance use services. Think about the triangle with 1 in 10 folks getting substance use services, and the mental health chart that showed that there was only half of the money that we needed in California for the mental health services. Now, one of the things that's important is that these kind of shifts aren't magically going to take place. And my belief is that, and a lot of other folks believe, that we can't invert this triangle without fairly dramatically changing the payment system in this country. So let's talk about that after we talk about coverage expansion. Nationally, we're looking at about 16 to 20 million more folks coming into Medicaid, which at a minimum is 40% more folks than we have now. And so this, as I said, is going to create a large reduction in uninsured. And what that means is that if you happen to be working, wherever you're working, an FQHC, a mental health center, a substance use provider organization, or an organization that's managing those services, and there's some number of uninsured folks, a lot of those folks are going to become insured, and there will be payment that companies their insured status to pay for the care in ways that it's not able to be paid for now. The future funding environment is going to move away from fee-for-service. I've been quoted as saying fee-for-service is dead. It's not dead tomorrow, but it's going to be dead the day after tomorrow. And that it's going to roll out. It's actually starting to roll out in a phased approach. And there's new funding mechanisms that are going to be used to manage the total health expenditures, including case rates to help pay for the prevention and early intervention and care management services, and a substantial bonus layer that could represent 20 to 30% of how much a provider organization gets paid if it provides high-quality services and help manage costs. The hospital system is moving to this bundled payment model, which are much more robust case rates than we have now. And these things are all going to be organized and managed by accountable care organizations, which is a new acronym that we get to be thinking about and working on. Starting as early as 2011, the accountable care organizations are going to be rolling out as a way to as organizing structures for managing primary care clinics, specialty clinics, and hospitals into a way to manage bundled payments for inpatient care and for helping support primary care clinics to improve quality and lower costs. The way that it's going to work is the payment will come from the health plan or directly from the feds to this new organization called an accountable care organization with a medical home at the center. And those folks will basically be given the opportunity and responsibility for managing quality, improving quality, managing costs, and with the potential for fairly substantial rewards going to those organizations. If you haven't, if you're not familiar with the term accountable care organization, now is the time to do some Google searching on the web, because this is the model that's going to be coming into place for places to complement the kind of way that the Kaisers of the world that are organized, which are already accountable care organizations. And what the future holds is that we're moving into an environment where most of the folks are going to have coverage. I haven't mentioned this before, but the aged, blind, and disabled in California are going to be shifting from fee-for-service into managed care on the healthcare side. The health plans are going to be at risk for managing the care and the costs for the coverage expansion population. And basically, this is going to be pulled together through accountable care organizations managing, helping the clinics and hospitals manage themselves, or the integrated delivery systems, which Kaiser is an example of an integrated delivery system. And what's very important in my radar screen is that mental health and substance use providers need to be looking at how to participate in the accountable care organizations and in integrated delivery systems so that you can be part of this emerging ecosystem that's happening in the healthcare delivery system. As I think about California, there are at least 8 raw ingredients, including the CMSP and MISP, managed care plans, the different mental health structures that are in place through the counties, the different drug and alcohol structures that are in place, and basically these need to be organized into an organized system of care. The 1115 waiver renewal for the health side on Medi-Cal is really going to push this. And what we're trying to get on people's radar screens is that the coverage initiative, which is going to be rolling out, the expansion of that, which is going to be rolling out, is going to be helping folks who are currently uninsured move into Medi-Cal sooner than 2014. There are a number of counties around the state that are looking at expanding the Medi-Cal health plan benefit package to include substance use services before 2014 because of the cost savings that folks like Kaiser have realized, and really working with implementing medical homes and accountable care organizations to help fund these systems. This is just a slide of an example of a kind of a budget model that we're working on as an example of this. And I really want to finish by saying that healthcare reform and parity changes everything in terms of how the systems are organized, how it's creating a tipping point for the fact that we have to address in a more robust way the needs of persons with mental health and substance use services in order to bend the cost curve. And it's going to change the way that healthcare is funded very differently than how it's funded now. And so we need to be thinking about how we get paid today in a different way than how we get paid tomorrow. So on that note, we're going to shift gears, and we're going to field some questions and answers.
Okay, thank you, Dale. This was a stimulating presentation. And we are now going to turn to the audience's questions. We have about 15 minutes for written questions, and I'm just going to start going down the list. Ooh, I apologize, folks, if you're hearing some feedback. So one of the first, there's a group of questions about the 2 visit per day limitation with the FQHCs. And so one of the questions is, one of the folks said that they had met with the State Department of Health Services and that there was not a sense from that meeting that there was likely to be a change in the 2 visit per day limit on the FQHC visits. So that's just a comment, I think. And the question related to that was that the state director really stated that the FQHCs need to bill differently and that it can be done within the current billing code. So any thoughts on that?
Well, what they were meaning was that if you have things that ancillary services that you're providing in an FQHC that don't rise to the level of being an allowable encounter, you can fold that into your per visit. You can attempt to get a rate change to increase your per visit cost because you've got other things that you're doing that are making the countable encounter, cost per encounter, higher than what you were doing yesterday. And so some FQHCs have basically followed the rules around how you can change your cost per encounter rate and then gone through the process of getting a higher rate per encounter to be able to cover some of these costs. So you have to be very careful about making sure that you cross all your T's and dot all your I's around that. Now, and so that's a strategy that folks indeed are pursuing. the problem is there's a time lag around getting approval for higher rates, and sometimes it takes quite a long time, and clinics don't have the cash flow to be able to support that in the meantime. The other comment I want to make is this is something that the legislature, the California legislature, needs to tackle. So, you know, for the department to say that they don't think it's going to happen either means that they're predicting that the legislature won't buy it, or they think it's a bad idea and they're going to tell the legislature that they shouldn't support it. I'm not sure which of those things that it is, but I think it's critical. If you think about that one little picture that I had about the flow, the best practice flow using the impact model, it's actually a no-brainer that you don't want to have to schedule somebody to come back for a second visit with a visit with a behavioral health clinician. It's poor quality care and has the potential of really hurting the ability to manage costs. So I see this as a hugely sort of penny-wise, pound-foolish move if California thinks it's going to save money by continuing to prevent this from happening. But of course, I have strong opinions about a lot of things. So
let me pursue along the same vein. I think the answer fits in with what you just said. But another question is, can FQHC services, or can primary health care services be provided by FQHC staff outside of the four walls of their clinic? In other words, could they provide those services within a substance use provider setting or a mental health clinic? And I think part of your answer is that if they did, they would still need to fold that into their basic FQHC single visit per day rate wherever they provided them. Is that inaccurate?
Oh, so let's see. Let me just restate what you said and make sure that I'm tracking this right. So I am a doc, and I'm going to, and I talk, me and my colleagues talk to the mental health center, and we say, oh my gosh, there's all these folks that are going to the mental health center on a regular basis, and they're getting their mental health care, and they're having a hard time getting over to the primary care clinic, and they feel really comfortable at the mental health center. So I'm going to start a day a week at the mental health center providing services, which is what a number of docs are doing around the country who work in FQHCs. And what will happen is I'll provide the service, and I'll get paid on a per visit basis. That's kosher, and it doesn't really require a rate change because you're simply just providing the same services you provide now at a different site. What it does require is a scope of project change so that you're adding the mental health center as one of your sites. And basically most of the time you're going to, so I should say for all intents and purposes, you need to change your scope of projects so that you list the mental health center as one of the sites where you're providing, one of the new sites where you're providing that service, and you need to do that in advance so that you make sure that you're not going to run into any problems with your project officer at the feds.
Okay. So we have a ton of questions here. Obviously this is a hot topic, but just quickly here, can FQHCs currently claim for substance use services provided that it is within their scope of services? Can this be done without calling them dual diagnosis mental health services? So can FQHCs claim now for substance use disorder services?
Well, I'd like to answer that question in two parts. There's as long as you stipulate this, and remember it's services, sites, and providers, and as long as you change your scope of practice to include this, and there's a whole piece around you have to make sure that the type of clinician that's providing these services is an allowable clinician, and so that you can bill it as an encounter or billed as what's called incident 2, which is a whole rich conversation. So there's 2 different approaches to that, or fold it into the rate in the way that we were talking about the 2 visits. So there is a way to do that. You may remember that on the slide that I talked about earlier, the healthcare reform bill changed the rules so that allowable clinicians include master's level substance use providers. So that this whole area of, can I bill it under my ID? Do I bill it incident 2 is going to shift because of that. So the short answer is yes, as long as you cross all your T's and dot all your I's, but you have to be very careful about who's providing the services and whether your scope of project has changed. The second piece is the feds have the National Office of Drug Control has come out with their plan to fund brief screening and brief intervention in FQHCs related to substance use services, and there's a substantial amount of money that's going to be flowing to FQHCs officially for this purpose. So this is another thing that people want to get on their radar screen, where the feds have basically said they were looking at that triangle and they're saying, oh my gosh, 10%. We've got to deal with the other 90% that aren't getting services. And the way we're going to start that is by putting money into FQHC's new money to fund the substance use services. So that's really important for all of us to keep an eye on how that money is going to start flowing.
Okay. We have a couple of questions related to your comments about starting with clinical design. Let me just give you the first. And this, I believe, came, so you said that we should start with the clinical design, but then you talked about services and providers that aren't reimbursable at this point. Shouldn't we design our clinical model without those non-reimbursable elements? It seems like we can't just start with the clinical model, unfortunately.
So let's see. The reason why I said it the way that I said it is because if you look at what's happening around the state, basically people are going, oh, they're creating a clinical design that's evidence-based, and then they're doing that first, and then they're asking the second question of, can I fund this, knowing that I can't fund it with just FQHC money, but a lot of counties are saying, I have MHSA dollars that have that don't have to go through all these wild and rigorous hoops that cause me to run into a brick wall. And so there's a lot of communities that are using MHSA dollars to fund some of the stuff, services in FQHCs that aren't currently fundable by FQHC. So if California didn't have the MHSA, I would be giving you a different advice. But because there's so many communities, so many integration projects that are able to use this more flexible funding, I think that's my starting point. And if you create a situation where you can't afford to fund your clinical model after you've graded and blending all the funding, then absolutely you're going to need to revise the clinical model so that you don't go broke. But I recommend, because there's enough experience doing this, to try and take a shot at funding a good clinical design. And I mean, this is something that may take like a couple days to figure out, so it's not like you need to go through a 9-month process before you say, oh, Dale sent me down the wrong path and now I have to start all over again.
Okay, shifting gears again. Could you say more about what an FQ behavioral health center is or would be? How would they intersect with the community mental health system? Would they be funded the same as FQHCs and have the same benefits like the 340B drug pricing? And this is future hopeful thinking, but.
Well, the legislation that's going to be coming out about this actually is the legislation that's materializing around this basically says the following. We want to have the HHS create a set of regs, and we want to move to a prospective payment system. That's if any bill were to get passed, those would be two of the things that will probably be in it, with the idea being that existing mental health providers and existing substance use providers and existing FQHCs, if that makes sense, could apply to become federally qualified behavioral health centers. So what we're talking about is taking the existing delivery system and allowing them to sort of get the good housekeeping seal of approval. Chances are this is going to roll out in phases, so that in phase one there won't be a grant pot like the 330 grant pot, and there may or may not be the 340B drug pricing. That's all to be, it's still in the we don't know yet phases. One of the things that's really important to note is that the FQBHC effort is not, let me underscore, not going after the 330 grant funding. That is really, really important money that needs to be allocated for the primary health care system, and any new monies that would come for FQBHCs for those type of grants would need to come from a different pot of money that would be authorized by Congress.
Okay, so just another quickie, and I think then I'm going to get to what may be the final question. Is there any place online that you would recommend folks who want to learn more about the FQBHC concept to try out heading for?
Let's see. What we'll do is there in the healthcare bill, the best, okay, so let me start over again. The best answer to that question is to read a paper that I wrote last year that talks about this, and secondly to look at the language that was in the healthcare reform bill that defines what an FQBHC is. And Gail, is it possible for me to get the links to you so that you can get those links put up on the CIMH website?
Yes, we can do that, and we can also send the links to the folks who have registered on this webinar. So Dale, I'm going to just move to one final question, and we will, you can send those links, and we'll try to also work with you on some of the unanswered questions that we have here. But the final question is, how do you propose that mental health and substance use services model their funding streams? How could they model their funding streams to better fit into the ACO, the Accountable Healthcare Organization concept? And I think another attachment to that really as a question is, where's the best place to find out about ACOs? And again, if you have some resources, we can try to get them posted and sent out to folks. But how would you propose positioning that?
Well, I think that, so let's just pretend for a minute that in California, the funding in the future in terms of the carve-out for mental health and the separate funding for alcohol and drug, and then the third category of healthcare funding stays just like it is. What I would do is, if I were a county, let me just use the example, is if I were a county, on mental health, or let's just say I was a county behavioral health department that managed both mental health and alcohol and drug. What I would do is I would get to the table of the organizing table. I'd find out where the meeting is that folks are meeting to organize ACOs in my community, and I would come there and I would bring the evidence about how important it is to provide mental health and substance use services to help these ACOs succeed, and we're actually going to have a document that's available for folks that's a business case for integration that's going to be coming out very shortly. And I would basically say, you know, we can help you guys and gals succeed at an ACO, and what we can do is we can bring to the table our mental health and our drug and alcohol funding, and we can bring together our expertise in helping folks deal with their mental health and substance use conditions, and bring our care management model for dealing with their chronic health conditions, and basically pitch the case for becoming part of an ACO. So, for example, in Eugene, Oregon, the mental health system the public mental health system down there is one of the members of the ACO group in that county. That county is organizing itself as a single ACO, and the mental health folks are at the table, the substance use folks are at the table, and they're basically getting in on the ground floor. There's an ACO webinar that I did about a month ago that I'll send the link for, and then there's some really good materials that have been written on ACOs that I'll send the links for that as well so that people can follow up on this.
Okay, well, thank you. And I'm afraid we are out of time and have to leave things here for today. We have a number of questions that still have not been answered, so I think it speaks to the richness and the level of interest in the topic. So our thanks to all of you for attending this last webinar in our 6-part series, Integrating Primary Care, Mental Health, and Substance Use Services. I would like to again thank Dale Jarvis for this really stimulating session on paying for integrated services, and to remind you that this webinar was recorded and will be posted on the CIMH Integration Initiative webpage at the link that you can see on your screen at this time. The slides will also be posted on the website, and they were mailed to you earlier if you were registered. Finally, I would like to acknowledge CIMH's partners in this webinar series, the Alcohol and Drug Policy Institute and the Integrated Behavioral Health Project. This truly was a collaborative effort, and we hope to secure resources to continue our integration webinar series again starting in the fall of 2010. So feel free to contact us with your recommendations regarding future topics. And again, thank you all and have a great afternoon.